Assalamualaikum. First, I hope you are doing well. The topic I'm going to be presenting today to help you with your midterms. Moving forward, I will repeat about epilepsy and move forward. So, first of all, let us talk about epilepsy. What is epilepsy? Epilepsy is described as a group of neurological disorders characterized by recurrent epileptic uh, seizures. Epileptic seizures are episodes that can vary from brief and nearly undetectable periods to long periods of vigorous shaking. These episodes can result in physical injuries like fractures. In this condition, seizures have a tendency to recur and may not have an immediate underlying cause. Isolated seizures that are provoked by a specific cause uh, can represent epilepsy. People with epilepsy can be treated differently in different areas, and it has a social stigma attached to it. Uh, Before moving onwards, I have to tell you that the cause of epilepsy is generally unknown, but some cases occur as a result of brain injuries, strokes, tumors, infection of the brain, or birth defects. Known genetic mutations are seem to be linked with small proportion of the cases. Uh, what has been seen that epileptic seizures are the result of excessive and abnormal neuronal activity in the cortex of the brain. The diagnosis involved ruling out other conditions that may cause similar symptoms, for example, fainting, and determining if any other cause of seizure is present, like, for example, electrolyte problems. Uh, this can be done with brain imaging and performing blood tests. Epilepsy can often be confirmed with an electroencephalogram, but a normal test does not rule out the condition. Moving onwards. Now we will briefly explain or discuss which is important, and that is the classifications of epilepsy. So as we know that epilepsy are seizures that can occur in an individual. Now what is important here is to understand how are they classified. So the classification, as you can see in the slides, I will tell you about some of these. Now, they are generally classified clinically as partial or generalized. Partial seizures involve only one portion of the brain at their onset. For example, temporal lobe can be involved, although these may later become generalized. For example, secondarily generalized tonic-clonic seizures. So let's talk about them. Generalized tonic-clonic seizures or grand mal seizures. We are going to talk about the grand mal seizures first. Uh, these there is a sudden onset of a rigid tonic phase followed by a convulsion, a clonic phase, in which the muscles jerk rhythmically and the eyes remain open. Normally speaking, this episode usually lasts for a few seconds to minutes, may be associated with tongue biting and incontinence of urine. Tongue biting, that during the period of seizure, they can literally bite their tongue as they cannot control their movements. And is followed by a period of placid unresponsiveness, uh, followed by confusion or drowsiness lasting several hours. Headache is common after a tonic-clonic seizure. Typical absent seizures or petit mal seizures. So we are going to talk about now petit mal seizures. So about these seizures, there is usually a disorder of childhood in which the child ceases activity, stares and pales for a few seconds only. It is normally characterized by a 3 Hz spike in wave activity on the electroencephalogram. Children with petit mal tend to develop generalized tonic-clonic seizures in adult life. So that means that epilepsy can progress, petit mal epilepsy can progress into grand mal epilepsy. Myoclonic tonic kinetic seizures. Now we're talking about the other seizures. There is isolated muscle jerking. If there is isolated muscle jerking, it is myoclonic. If there is intense stiffening of the body, it is considered chronic. If there is sorry, a cessation of movement, movements are ceased or stopped, uh, falling and loss of consciousness, it is akinetic. Apart from that, partial seizures involve epileptic activity in part of the brain and are simple, for example, not affecting the memory or consciousness, affecting awareness of memory before, during, or immediately after the seizure episode. Parents with focal seizures have symptoms depending upon area of the brain where the seizures start, often the temporal lobe. The seizures may become generalized to affect the whole brain. Uh, Certain motor seizures, like Jacksonian seizures, originate in the motor cortex. These typically result in jerking movements, typically beginning in the corner of your mouth, thumb, and index finger, and spreading to involve the limbs on the opposite side of the epileptic focus. Paralysis of the involved limb may follow for several hours. Temporal lobe seizures are associated with olfactory and visual hallucinations, blank staring, feeling of unreality or undue familiarity, like deja vu, with the surroundings. So this is briefly about the seizures, and I have discussed the important uh, type of the seizures. Um, about the etiology and precipitants, it has been seen that hippocampal sclerosis is the main pathological cause of temporal lobe epilepsy. Childhood febrile convulsions are the main risk factor. It is usually visible on MRI and is one of the most common causes of refractory epilepsy, in which case it may be amenable to surgical resection of the damaged temporal lobe. Apart from that, metabolic disturbances like hypoglycemia, acute hypoxia, hypocalcemia, hyponatremia, and uremia uh, uh, usually present with convulsions as well. Evaluation and investigation. Now, there are three steps in the evaluation of a patient with epilepsy. So I will write here three steps. Three steps are followed and evaluating a person with epilepsy. Number one, confirm if the patient has epilepsy. The diagnosis is made clinically, and a detailed description of the attack from an eyewitness is invaluable. Disorder causing attack of altered consciousness may be differentiated from epilepsy. Two, determine the patient's seizure type, like from the classifications I have told. Finally, number three, identify any underlying cause for epilepsy. Electroencephalogram is used to assist in the classification of epilepsy and to confirm the clinical suspicion. During a seizure, the EEG is almost always abnormal. And second is brain imaging. It is indicated in all new cases to exclude any underlying lesion. CT is used in emergency settings to look for any space occupying lesion, for example, if there is any tumor, or MRI with imaging of the hippocampi in usually routine cases to study epilepsy. Management. Certain emergency treatment is used to ensure that the patient does not harm themselves or as little as possible as the airway remains patent. Normally, seizures stop spontaneously. A prolonged seizure, which is longer than 3 minutes, or repeated seizures are treated with rectal diazepam, lorazepam, and repeated seizure. A brief period of recovery may lead to status epilepticus. So, it is imperative that I talk about status epilepticus. As it is written, it is actually a medical emergency. There is actually a continuous seizure for 30 minutes or longer, uh, or two or more seizures without recovery of consciousness between them over a similar period. When grand mal seizures follow one another, there is actual risk of death from cardiorespiratory failures. The precipitating factors in a non-epileptic include the abruptly stopping anti-epileptic treatment, alcohol abuse, or other poor compliance therapies. Normally, rectal diazepam can be given out of hospital. So let us talk about its treatment briefly. Generally, what we have to do is to give administer oxygen, must secure any venous access through any vein, blood glucose and other factors. Cardiovascular monitoring is necessary. Thiamine is given. For example, if nutrition is poor, thiamine is one of the commonly given multivitamins, vitamins. So, how to control that seizure? The first line drug is lorazepam. If seizures continue, the second order drug is phenytoin. And the third order is phenobarbital. Investigations include brain CT scan, lumbar puncture, and blood cultures. If the status is finally controlled after this treatment, anticonvulsant therapy is continued to prevent any other cysts. Moving onwards, now we will talk about another important topic, which is multiple sclerosis. Let's discuss a bit about multiple sclerosis. It is actually a demyelinating disease in which the insulating covers of the nerve cells in the brain and spinal cord are damaged. So, if we move forward, now observe here. This is the nerve fiber and the myelin sheath that covers them. Now look what has happened here. The myelin sheath has damaged, exposing the underlying nerve fiber, which can lead to numbness, tingling, pain below the lesion. This is the characteristic feature of multiple sclerosis. Apart from that, this damage disrupts the ability of the parts of the nervous system to transmit signals, resulting in a range of signs and symptoms, including physical, mental, and sometimes psychiatric problems. Specific symptoms can include double vision, blindness in one eye, muscle weakness, and trouble with sensation or coordination. This multiple sclerosis can be in various forms, with new symptoms either occurring in isolation or build up over time progressively. Normally, a person with multiple sclerosis can have almost any neurological symptom or sign, with autonomic, visual, motor, and sensory problem being very common. The specific symptoms are determined by the location of the lesion within the nervous system and may include loss of sensitivity, changes in sensation like tingling, pins and needles, etc. Uh, Muscle spasm or difficulty moving can be seen. There can be coordination, balance problems, problem with speech and swallowing, bladder dysfunctions, difficulty thinking, and even emotional problems can be seen. So a lot of symptoms can develop due to multiple sclerosis. This is the pathophysiology, which you can see how it affects the nerves. Epidemiology, it usually becomes early adulthood, twice as common in women as compared to men. Talking about the etiology of this disease is also very interesting. Now, the important factor about the etiology here that you have to know. Normally, the mechanism is unknown, but there is actually an autoimmune mediated attack where your own immune systems affect or damage the nerves. Usually, it is mediated by B cells and the CD4 T cells. So what it means, now this is the normal nerve. What happens is your own immune cells attack your nerves, leading to such a condition as you can see exposed nerve fibers over here and the myelin sheath being damaged. This is due to an autoimmune mediated response of the body. So it can lead to inflammation, demyelination, and axonal loss. Uh, Briefly, if we discuss its clinical features, oh sorry, its types, uh, it is can be a simple syndrome. It has relapsing remitting. It can be primary progressive multiple sclerosis or secondary progressive multiple sclerosis. So we'll talk about these conditions first, briefly. Relapsing remitting multiple sclerosis is characterized by unpredictable relapse followed by periods of months to years of relative quietness or remission with no new signs of the disease activity. Deficits that usually occur during attacks may either resolve or leave problems later in about 40% of the cases. Uh, Primary progressive multiple sclerosis. About this condition, it has been seen that primary progressive multiple sclerosis uh, there is seen in individuals with no remission after the initial symptoms. It is characterized by progression of the disability from onset with no or only occasional and minor remissions and improvements. The usual age of onset for the primary progressive subtype is later than that of the relapsing remitting subtype. And it is similar to the age that secondary progressive usually begins in relapse remitting multiple sclerosis, around 40% of the age. Next, secondary progressive multiple sclerosis. Normally occurs in 60% of those individuals with initial relapse remitting multiple sclerosis. So that means that relapsing remitting MS can progress to secondary progressive MS. They, with eventually having a progressive neurological decline between acute attacks without any definite period of remissions. Occasional relapses and minor remissions may appear. The most common length between disease onset and conversion from relapsing remitting to secondary progressive MS has been seen or observed to be 19 years. Investigation is through MRI and uh, of brain spinal cord and is the investigation of choice in these patients. Apart from that, electrophysiological tests can also be done. Management, as there is inflammation present, steroids most commonly used is methylprednisolone. 100 mg per day for 3 days is good. Apart from that, beta interferons seems to interfere with the seem to reduce the rate of relapse by one third. Now, as I have told you that there is an immune response, so interfering with the immune system may help. Apart from that, Latimer acetate uh, also seem to improve patient conditions. Apart from that natalizumab is reserved for second-line therapy. The physiotherapists, that are you people, usually maintain mobility of the joints and help in muscle relaxation and reduce pain and discomfort as there may be spasticity. So certain techniques to reduce spasticity can be done. Now we will talk about the nervous system infection and inflammation pathologies. In that, the most important one is meningitis. So what is meningitis? Meningitis is actually an acute inflammation of the protective membranes covering the brain and spinal cord. The most common symptoms include fever, headache, and neck stiffness. Other symptoms are confusion, altered consciousness, vomiting, and inability to tolerate light and loud noises. Young children exhibit non-specific symptoms such as irritability, drowsiness, or poor feeding. If a rash is present, it may indicate a particular cause of that meningitis. For example, meningitis caused by meningococcal bacteria may be accompanied by a rash. Apart from that, in adults, the most common symptom of meningitis is a severe headache, occurring in almost more than 90% of the bacterial meningitis, followed by neck stiffness. The classical triad diagnostic sign consists of neck stiffness, sudden high fever and altered mental status. If But that is not specific to every case. If none of the three signs are present, acute meningitis is extremely unlikely though. Other signs common associated with this condition is photophobia, phonophobia. Phonophobia is inability to tolerate loud noises. Although some small children often do not exhibit the symptoms and can be irritable and look unwell initially, but it can progress. We will now move forward. It can be a viral, bacterial, or chronic type. Of that, the bacterial meningitis is very important. So we'll talk about it. Now, the type of bacteria that causes bacterial meningitis vary according to the infected individual's age group. For example, in newborns, the most common causes are group B streptococci, affected by Neisseria meningitidis virus or Streptococcus pneumoniae. In adult, Neisseria meningitidis and Streptococcus pneumoniae usually together cause 80% of the bacterial meningitis cases. Apart from that, the symptoms are the same. If photophobia present, phonophobia can also be present. Clinic sign is very important. It is the inability to allow full extension of the knee when the hip is flexed to 90 degrees. So what happens here is if you flex your hip to 90 degrees and tell the patient to extend his knee completely, he will be unable to do so. So this is briefly about meningitis. While meningitis is usually benign and lasts for 4 to 10 days with no serious sequel, chronic meningitis, if there is long history, and can have headache, lassitude, anoxia, and vomiting. Different diagnosis: hemorrhages, migraine, and viral encephalitis. So, if there is uh, bacterial meningitis, briefly uh, we can treat it as by first of all identifying if there is any presence of rash. Investigation include head CT, lumbar puncture. Treatment obviously involved antimicrobial therapy if needed. So third generation cephalosporin or amoxicillin is important. If it is tuberculosis meningitis, then it is treated for 12 months. The next topic we will cover now is encephalitis. We will talk about it briefly. It is actually the inflammation of the brain or the brain parenchyma. The severity can be variable with symptoms like headache, confusion, stiffness, vomiting. Complications may include seizures, hallucinations, trouble speaking, memory problems, or any other case. Causes include viruses like herpes simplex or rabies. Even bacteria can cause it. Other causes include autoimmune diseases and certain medications. In many cases, the cause remains unknown. Risk factor includes a weak immune system. Diagnosis is usually based on MRI, blood tests, medical imaging, and fraction of cerebrospinal fluid. People should only be diagnosed with encephalitis if they have a decreased or altered level of consciousness, lethargy, personality changes without any explainable cause. Diagnosing syphilitis can be done through brain scans, EEG, lumbar puncture, blood tests, urine analysis. Briefly talking about its treatment, it is usually supportive care like antiviral medications is where there is any viral pathology, antibiotics if there is bacterial cause, steroids are given to reduce the brain swelling, sedatives for restlessness, acetaminophen for fever, and occasional physiotherapy can also be given. Uh, for example, after infection, there will be any symptoms neurological. Then physiotherapy can also be given. Abscesses are can be epidural, subdural, intracerebral. Cerebral abscess usually involve infection from follow direct spread of organisms from parameningeal in infected focus or a distant source of the infection. Spinal epidural abscess, back pain or fever after paralysis, neurosyphilis occurs late in the course of an infected disease. Creutzfeldt-Jakob disease is characterized by progressive dementia, develops after 50 years. HIV and neurology, HIV-infected individuals can also develop brain abscesses. Now we will move forward to our main topic, which we will study is Parkinson's disease. Now, Parkinson's is actually a long-term degenerative disorder of the central nervous system that affects the motor system. As the disease worsens, non-motor symptoms also become common. Symptoms are usually emerge slowly. Early in the disease, the most obvious symptoms are shaking, rigidity, slowness of movement, and difficulty with walking. Thinking and behavior problems can also occur. Dementia becomes common in the advancing stages of the disease. Depression and anxiety are also common in these cases. uh, its etiology is actually unknown, but it has been seen that there is a genetic and environmental component. Those with a family member affected are more likely to get the disease themselves. There is also increased risk in people exposed to certain pesticide based on certain evidence. The motor symptoms of the disease result from death of the cells in the substantia nigra, a region of the midbrain, but, uh, but the cause is usually poorly understood. But it has been seen that there is actually buildup of proteins in the Lewy bodies in the neurons. Diagnosis is basically based on symptoms. Now we will talk about an important factor that are the clinical features of this condition. Four motor symptoms are considered cardinal in Parkinson's disease. So we will discuss this. What are the four cardinal symptoms? Tremor, slowness of movement called bradykinesia, rigidity, and postural instability. So four cardinal symptoms are there. are these. I repeat, tremors, slowness of movement, rigidity, and posture instability. The most common presenting sign is a coarse, slow tremor of hand at rest, which disappear during voluntary movement of the affected arm and in the deeper stages of sleep. About bradykinesia is found in almost all cases, most cases of Parkinson's disease, and it is of movement initiation associated with difficulty along the whole course of the movement process. From planning to initiation to execution of a movement, performance of sequential and simultaneous movement is usually impaired. Rigidity is stiffness and resistance to limb movement caused by increased muscle tone and excessive and continuous contraction of muscles. In this condition, the rigidity can be uniform, known as the lead pipe rigidity, or rigidity, known as the cog rigidity. Postural instability occurs in the latest stages of the disease and leads to impaired balance and increased risk for fall, and can lead to fractures, loss of confidence, and reduced mobility. Investigations is usually based on clinical features, but dopamine transporter imaging can be done. Now we will talk about a very important concept in Parkinson's disease, and that is its management. Proper medication is extremely crucial in patients suffering from Parkinson's disease. Any fault or problem with medicine given can have dire or serious consequences. The most symptoms of Parkinson's disease are a result of reduced dopamine production of the brain's basal ganglia. Because dopamine does not cross the blood-brain barrier, so it cannot be taken as a medicine to boost the brain's uh, uh, reduced level of dopamine. However, levodopa can pass through the brain where it is readily converted to dopamine. Hence, it is the usual treatment of or medicine of choice to give to certain these individuals. Also, it has to be said that carbidopa and dopa carboxylase inhibitors, which do not cross the blood-brain barrier and inhibit the conversion of levodopa to dopamine outside the brain, uh, mm, reducing side effects and improving the availability of levodopa for passage into the brain. One of these drugs is usually taken along with levodopa, often combined with levodopa in the same pill. So what I'm saying is, okay, apart from levodopa, carbidopa or dopa decarboxylase inhibitors can be given along with this drug to improve its efficacy. Apart from that, dopamine agonists can be given, monoamine oxidase inhibitors can be also be given. uh, Monoamine oxidase inhibitors increase the amount of dopamine in the basal ganglia by inhibiting the activity of the monoamine oxidase B enzyme. Like the dopamine agonists, their use may delay the commencement of levodopa therapy in early disease. But these inhibitors produce more adverse effects and are less effective than levodopa in controlling Parkinson's disease motor symptoms. Physiotherapy is very important as we have a role in improving the gait, preventing falls, reducing the rigidity using techniques like that. So we have a very important role in improving the condition of an individual suffering from Parkinson's disease. Moving onwards, let's briefly talk about these conditions. In hydrocephalus, there is accumulation of cerebrospinal fluid in the brain, usually increase the pressure inside the skull. In children, it can be due to congenital malformation of the brain, for example, the Arnold Chiari malformation. Clinical features: there's headaches, vomiting, papilledema because of the raised ICP. Ataxia and bilateral signs can also be seen. Brain imaging is required, for example, to do or other different causes. Treatment is through a surgical shunt. A shunt is inserted between the ventricles and the right atrium. Apart from that, acetazolamide may help lower the intracranial pressure. Now we will talk about headaches, migraine, and facial pain. We talked about headaches briefly in the previous lecture. So let's move on and briefly talk about these conditions. Now, tension headaches are the most common type of primary headaches. The pain can radiate from the lower back of the head, neck, eyes, other muscle group in the body, typically affecting both sides of the head. The more important thing to remember about tension headaches is that usually has a duration between 30 minutes, 7 days. At least two of the four characteristics must be present. They are either bilateral location, pressing or tightening feeling, mild or moderate intensity, or non-aggravated by routine physical activity, no nausea vomiting, no more than one photophobia. Usually tension type headaches may be accompanied by tenderness of the scalp or manual pressure during an attack. I would like to repeat it again. You need to remember four characteristics. One is that bilateral location, pressure or tightening, pulsating quality, mild or moderate intensity, and not aggravated by physical activities. So, two of these four that I mentioned must be present. Apart from that, there should be no nausea, vomiting, or no more than one episode of photophobia. So, these are seen in tension type headaches. I just described that. Management includes careful assessment, discussion of the precipitants. Physiotherapy with muscle relaxation or stress management can also be. Let's talk briefly about migraine. It is characterized by recurrent headaches that are moderate to severe in intensity. The headache affects one half of the head, pulsating in nature and lasts from few hours to 3 days. The most important thing you have to remember, there are four possible phases of migraine, though not phases may be experienced. One is the prodrome, which occurs hours or days before the headache. uh, Prodrome, I should explain, it is an early sign and symptom uh, that often indicates the onset of a disease before more diagnostically specific signs and symptoms develop. uh, so that is a prodrome. Next is the presence of aura. Aura, which immediately precedes an headache. It is a general feeling that a headache is about to come. I can feel it, something like that. Then the pain phase, also known as the headache phase, when the headache starts. Postdrome, where the effects experienced follow the end of the migraine attack. Usually, there is seen changes in the brainstem blood flow that leads to unstable uh, uh, effect of the trigeminal nerve nucleus and nuclei at the basal thalamus. Classified into three types. If there is aura, classic migraine; without aura, common migraine; or migraine variants, uh, unilateral motor or sensory symptoms resembling a stroke. Management, mild attacks can be given. In mild attacks, simple analgesics or paracetamols can be given. In moderate to severe attack, triptans, sumatriptans, can be given. Prophylaxis in patients with frequent attacks or those response poorly to acute attacks. Apart from that, anticonvulsants, beta blockers, or imidazole can be given. Cluster headaches, rapid onset, severe, short-lived unilateral headaches are called cluster headaches. Pain begins around the eye or temple. Autonomic features are lacrimation and redness of the eye. Treatment of an acute attack is subcutaneous or nasal triptans or inhalation of oxygen. Briefly talk about the next topic, that is facial pain. Facial pain simply as the face has a good supply of pain sensitive structures. So disease which can cause facial pain mostly involve the fifth nerves, trigeminal nerve that supply the area of your face. And trigeminal neuralgia can present with facial pain. Now we will briefly discuss spinal cord diseases. We know cord extends from C1 to L1. Cord compression is a medical emergency where there's compression on the cord. We have discussed this topic before. So, most common cause of this is uh, acute cord compression is vertebral tumors. MRI and X-ray are commonly used for investigation, and treatment depends on the cause. Dexamethasone usually reduces edema around the area. Corda syndrome, distal to L1 are extensions of your nerve. The nerves extend after from the cords. Distal to L1, if such a thing occurs, it is considered to be Corda syndrome. So a lesion distal to L1 or at L1 is Corda lesion. The most characteristic feature is perianal anesthesia that you can see over here. This area is supplied by the sacral S3, S4, S5 nerves. So this area is affected, and this condition is called the saddle anesthesia, the perianal area anesthesia. This is a characteristic feature of Corda syndromes. Now we will talk briefly about syringomyelia and syringobulbia. Fluid-filled sacs within the spinal cord or brainstem. What you have to know is just this, that observe, this is the spinal cord, the brainstem, and this is the spinal cord. Notice this fluid-filled cavity or sac present within this cord, a fluid-filled cyst. This is known as syringomyelia, caused usually by a blockage of the cerebrospinous flow or CSF flow from the fourth ventricle, also associated with undercheery malformations. Next is Friedreich ataxia, an autosomal recessive disorder common in hereditary spinocerebellar degenerations. There is a progressive degeneration of the spinocerebellar tract and cerebellum, causing ataxia, dysarthria, and usually nystagmus. Uh, Also can include absence of the joint position and vibration sense, optic atrophy and pes cavus, and cardiomyopathy are also seen. Uh, Motor neuron diseases, you just have to remember uh, there is a destruction of the upper motor neurons. It has four types. Progressive muscular atrophy, as the name suggests, there is continuous degeneration or atrophy of the muscles with weakness and wasting. Amyotrophic lateral sclerosis, a combination of disease of the lateral corticospinal tracts and anterior horn cells, causing spastic tetraplegia or paraparesis. Bulbar or pseudobulbar palsy, we have discussed this before, is uh, uh, pseudobulbar upper and bulbar lower. Primary lateral sclerosis is usually rare. Characteristics is tetraplegia. Diagnosis is usually clinical, and differential diagnosis includes cervical spinal diseases, etc. Management include riluzole, a sodium channel blocker that inhibits glutamate release and slows the progression slightly. Now, briefly, we will discuss the peripheral nerves. Six mechanisms that you have to know: demyelination, axonal degeneration, volume degeneration, compression, infarction, and infiltration by inflammatory cell. Mononeuropathies, there is usually the effect of a single nerve or a multiple mononeuropathy or a mononeuritis multiplex process affecting several or multiple nerves. acute compression, entrapment, or trauma. Of that, I will only talk about one which is important, that is the carpal tunnel syndrome. As you can see, tendon pass deeply through this transverse carpal ligament. What happens in carpal tunnel syndrome, I will represent it as CTS. There is actually inflammation or tendinitis of these areas leading to edema and tightening. Now there are receptors here which divide the area or tendons crossing through. Now the nerves and the muscles are in close contact with one another. When they inflame, they start compressing the nerves, leading to pathology of the median nerves. As you can see here, when there is CTS, there is numbness of usually three, or sometimes there's a very narrow line here, 3.5 part of the fingers. This is the mono example of a mononeuropathy. Features are pain paresthesia. I've shown you management, splints or steroid injection. As there is inflammation or edema, steroid will reduce it. Apart from that, splinting the place using a splint can reduce the symptoms. Polyneuropathy, an acute, chronic, diffuse, usually symmetrical disease process that involves the motor, sensory, and autonomic nerves, which is commonly seen. Uh, Guillain-Barré syndrome is acute neuropathy and is a common polyneuropathy. It is usually triggered by an infection characterized by a progressive onset of distal weakness. Reflexes are lost. Sensory symptoms can also be seen. Disability can be mild or severe. What important here is that there is an autoantibody mediated nerve cell damage. Uh, Diagnosis is usually clinical. Management is monitoring the vital capacity, IV immunoglobulin, and supportive treatments like heparin. Muscle diseases that lead to weakness is a prominent feature. It can be reflexes or sensations are usually normal. This is the very important difference between a muscle disease and a nerve disease. In a nerve disease, there is a weakness plus reflexes and sensation loss. In muscle disease, the reflexes are not affected. Just we have to remember that acquired can be acquired or genetic, acquired can be inflammatory cause due to endocrine problems or myasthenic, like myasthenia gravis. Genetic is dystrophic, myotonic, channelopathies, or metabolic problems. So class, with this, our lecture or revision part has been concluded. You kindly review it before you conduct your midterm exams, as this review lecture may help you in understanding an important point or topic that may have been needed. If you have any questions, you are free to